Hello, everyone. I'm Kartik Sehgal. I'm the director for Thyroid Cancer Center at Dana-Farber Cancer Institute and Brigham and Women's Hospital. I'm very excited today to be joined by my illustrious colleague, Dr. Wirth. Dr. Wirth, would you like to introduce yourself?
Thank you. Yes. Hi, everyone. I'm Lori Wirth. I'm the Elizabeth and Michael Ruane Chair of Endocrine Oncology at Massachusetts General Hospital.
Thanks, Laurie. Today, we'll be talking about the topic new targeted treatments for differentiated thyroid cancer. I think it's an exciting time to be working in the field of thyroid cancer with new molecular targets which have emerged over the course of last decade. When we are talking about differentiated thyroid cancer, we are referring to papillary, follicular, HER2 or oncocytic, and poorly differentiated thyroid cancer. The targets that we would be hoping to touch upon include BRAF V600E mutation, seen in about 40 to 60% of patients with thyroid cancer, and other targets that we will be talking about include rearrangements or fusions in RET genes and TRK, and then alterations in some other genes which provide future prospects. Dr. Wirth, will you like to kind of add upon to that introduction?
I think that it's fair to say that thyroid cancer really has emerged as a poster child for precision oncology in the field. Most of our patients have potentially druggable alterations when they present with advanced thyroid cancer. So the topic is really pertinent to what we do in clinic with our patients every day.
Do you recommend upfront molecular profiling for patients, especially with radioactive iodine refractory differentiated thyroid cancer, when they are especially seen in the medical oncology clinic?
Absolutely. I think that now each and every patient should have biomarker testing done when they have advanced iodine refractory differentiated thyroid cancer. Hopefully, it can be done prior to initiating the first line therapy for patients. I think there's also an emerging role for doing biomarker testing in patients who have very high risk disease for recurrence as well in the newly diagnosed surgical setting.
And I would completely agree with that. And I have tried my best to incorporate that into our clinical practice by utilizing either the research studies that we have at our institution or through commercial platforms. But as I'm sure you also see when we do see patients from some of the other centers, which are not academic community practice, I think we still have some work to do to disseminate that information.
Yeah, and Kartik, one thing that I think is worth mentioning along those lines is that it's a difficult decision to know which test to use. And because these gene fusions are seen in so many patients, I think it is important to make sure that when people are ordering biomarker testing, that they do just a little bit of homework to make sure that they're using a test that can identify all of the gene fusions that we see in thyroid cancer, including NTRK1, NTRK2, NTRK3, RET fusions, and ALK fusions.
I think you highlighted a very important point about RNA sequencing, especially because the regular DNA sequencing sometimes can miss some of these important alterations for which we have great therapies. So I think that's a perfect segue into talking about the BRAF V600E mutation. I know you've done a lot of work in that field, and I would love to hear your perspective on patients whose tumors harbor BRAF V600E mutation.
BRAF V600E is the most common potentially druggable alteration that we see in patients with advanced thyroid cancer. What's very interesting is that BRAF targeted therapy in iodine refractory BRAF mutant papillary thyroid cancer doesn't seem to work quite as well as our standard multikinase inhibitor therapies, particularly lenvatinib. So I think the most important trial was an NCCN multi-center trial that took a look at dabrafenib plus or minus trametinib in these patients, many of whom had had prior therapy, but some patients didn't have any prior therapy. And we saw that whether it was with dabrafenib alone or dabrafenib and trametinib, the response response rates weren't really nearly as high as what we saw with lenvatinib in the first or second line therapy. So I think that my take on this is, even though dabrafenib and trametinib now have a tumor agnostic approval by the FDA for BRAF V600E mutant disease, for the most part, we should reserve dabrafenib and trametinib for the second line setting in patients with BRAF mutant progressive iodine refractory papillary thyroid cancer, because I think that lenvatinib seems to work better.
One of the questions as a follow-up to that, which has often come up in discussion with other colleagues as well, if we have a patient who is older, relatively frail, not with absolute contraindications to lenvatinib, I think in that case, the answer is a little easier. But if it's an older person, frail, multiple comorbidities, but still candidates for systemic therapy with the BRAF V600E mutation, in those particular settings, what's been your practice in terms of starting with lenvatinib? The standard dose is 24 milligrams, starting with the lower dose, or kind of taking the targeted therapy approach directed towards BRAF V600E?
Well, I guess that has to be a case-by-case decision for sure. But there was the analysis that took a look at the older patients in the SELECT trial with lenvatinib that showed that there was an overall survival benefit in patients 65 years and older on the SELECT trial, despite the fact that there was crossover from the placebo arm to lenvatinib at the time of progression. So that overall survival benefit, I think, is important to keep in mind when we're thinking about older patients. But if the patient doesn't have a definite contraindication to lenvatinib, I would still try to use it. I do think that the data looking at the higher dose versus the lower dose, showing that the lower dose is not inferior, that the standard 24 milligram starting dose is the right dose to use. But you have to use your judgment. In an older, frail person, of course, I'll start with a lower dose than the 24 milligram dose to be judicious. But I think it is a reasonable approach in patients who are not good candidates for lenvatinib therapy, who have a BRAF V600E mutation, to use dabrafenib and trametinib in the first line.
That has been my personal approach as well. Any other thoughts in terms of the toxicities for BRAF MEK targeted therapy?
It's tricky because often patients do quite well. Some patients don't really have any treatment-related adverse events at all, as far as I've experienced. But sometimes people really do have trouble, particularly with this syndrome of fever and myalgias and flu-like symptoms. And that's just a difficult syndrome to manage. I think it ends up being manageable in most circumstances.
So kind of moving on to now less common targets, RET rearrangement is one of the other common, essentially actionable target that we look for patients with thyroid cancer. And I can talk about some of the data, which I know one of the papers was published by you, specifically looking at selpercatinib and the other selective RET inhibitor being pralsetinib. The data for both those selective RET inhibitors come from phase 1 and 2 studies, Libretto and Arrow, respectively, for selpercatinib and pralsetinib, with such impressive response rates. It's so heartening when we see response rates like those. And in addition to that, those response rates, which vary somewhere between 70%, 80%. And I would like to highlight the lesser adverse events, relatively speaking, between selpercatinib and pralsetinib. Dr. Wirth, do you use a guideline, or how do you select between those two options? I know there are some adverse event profile differences, pneumonitis being the more relatively more common with pralsetinib, but again at ranges of 5%, and maybe more QTc prolongation being seen with selpercatinib. But I would love to hear about your thoughts between those two agents if we have to select.
Well, of course, we have absolutely no head-to-head comparison between the two, so it's really very difficult to know if one drug is better in this setting than the other drug. I think you highlighted a couple of differences, and another minor difference I think between the two agents is you see a little bit more bone marrow suppression with pralsetinib than is seen with selpercatinib. But I've found that to be very manageable as well. I think that both drugs really are very good options for patients with progressive RET fusion positive, iodine refractory differentiated thyroid cancer, and certainly also in the first line setting. Instead of reserving one of those two drugs and using lenvatinib or cabozantinib or sorafenib first, I think that the response rates and progression-free survival and tolerability is really so good that we should not be saving them for second line.
I would absolutely agree with you. That's been kind of my practice as well. Our other target, NTRK gene fusion, I know you kind of commented on that. I would love to kind of hear your thinking about those targets.
Well, I actually like to talk about NTRK in the setting of thyroid cancer a lot because in the larotrectinib series, for example, the most common adult solid tumor enrolled was thyroid cancer tied with soft tissue sarcoma. And there was a study done with more than 11,000 genotype tumors that came out of Caris that showed that the highest frequency of NTRK fusions found in solid tumors was in patients with thyroid cancer. So if you're thinking about NTRK fusion-driven disease, top of in your mind, you want to be thinking about thyroid cancer. And both larotrectinib and entrectinib have good activity. The updated data for entrectinib had now I think about 25, 30 patients with thyroid cancer enrolled, and the response rates with entrectinib are pretty high. The response rates with NTRK fusion positive DTC with larotrectinib are very high, 89%. The drug is, both drugs are very well tolerated, and we see quite durable responses. So again, I think that NTRK specific therapy really should be first line therapy for these patients.
I absolutely agree with you. Again, the response rates are astounding, and we don't see that often in the field of oncology, where we see such great response rates and relatively well-tolerated drugs. Between larotrectinib and entrectinib, I'm curious because larotrectinib may be a bit more selective inhibitor compared to entrectinib. And do you have a preference between those two? I can share my preference. If I see a new patient, and again, I have patients on both those drugs and who are doing well. But I may tend to favor larotrectinib given its just selectivity for NTRK. Was curious to hear your thoughts.
I agree with you. I've come to the same conclusion. And then also in the larotrectinib series, there were more patients treated with thyroid cancer. So we just have, I think, a little bit more of a tighter confidence interval around the response rates, for example.
So I know we've talked about the targets for which we have approved therapies. Are there some other targets that you are excited about for future, and also for the targets that we talked about, some future trials?
Well, you mentioned in the introduction the PI3 kinase mTOR pathway, so I think we should touch on that very briefly, and I want you to do that.
Yes. So we've had phase 2 studies with everolimus, which is an mTOR inhibitor, and seen mostly stable disease. The response rates, unfortunately, if we define by RECIST, were 0 to 6%. But the stability was seen in up to 60 to 70% of the patients. So I have used that in an off-label manner, even though it's not FDA approved, when there are no other options available, including on clinical trials. But hopefully we can harness this pathway. I think there are a lot of steps in that, including PI3K inhibitors or combinations with some of the targeted therapies with mTOR inhibitors, which is something which I look forward to working on with the entire field.
I agree with you. I think there is something to exploit there. We need to figure that piece out a little bit better in the future.
Thank you so much, Dr. Wirth.
Thank you so much, Kartik. This was great.